Hello and welcome back. I'm Eric Sunset, your host of the Doc Buddy Journal, and today we're joined by David Howerton. Many of you in podcast land will be familiar with David, but for those who aren't, David's based in Nashville, Tennessee. He's a bona fide expert in the ASC space, and I'm not going to let him try to back that down at all. He is a bona fide expert. He's held executive roles with surgery center tech vendors like HST Pathways, Simplify ASC, and CSS OrMed, among others. David, thanks for joining us today.
Eric, good morning. Thanks for having me. It's great to be here and appreciate the opportunity to shoot the breeze with you today.
Oh my gosh, the pleasure is all mine. It's too bad we're so far apart. I'm in Miami, you're in Nashville. It's like maybe 15 hours up 95 and a little bit west.
Just a short drive. A short drive away.
Easy to get there.
That's right.
Well, thanks again for joining because we're really excited to get some of your perspective on the ambulatory surgery center space. It has been changing and evolving over time, really since its inception. But the changes seem to be moving much more quickly these days. There's a lot of macro pressure on the ASC space, things like private equity investments, health system interest, consolidation, all the, sort of all the pressures you're seeing in healthcare now. What are you seeing? What do you view as some of the most important pressures happening on the ASC space?
Right. You're so right, Eric. So much going on today in the healthcare space. I know we're going to touch on AI a little bit later on, but I think all of these macro trends really not just within ASC, but in healthcare in general. So this pocket of the healthcare system that we know as outpatient surgery has been, to your point, in radical change, in my opinion, over the last decade. I got involved in the space around 2015, and the scene was completely different. The actors were completely different. We still had an area of the market that was lagging behind hospitals and clinics, squarely focused on meaningful use initiatives in varying degrees. So all of the attention from the investment community, from the big technology vendors, all of that was still focused on trying to work out how to make hospitals and physician practices more efficient and effective with technology. And once that ran its course a little bit more and the market matured, now you start to see this gaze turn upon the surgery center space, a market adjacency that people looked at like, gosh, this is ripe for investment. It's a beacon of light in the healthcare space with its efficiencies, and that the natural tendency is to move into that with some of these things that we're talking about today. So, big picture items that I think about today, obviously, and probably you will hear these from other folks as well. Right now, labor, anesthesia, where are we with the investment? The investments from private equity today. What do the public markets look like? So that consolidation. So these big trends are going to have impacts, throughout the rest of this year and into next year, depending on where we are with the economic climate in the U.S.
Yeah, I mean those are all huge, and you've heard me here on the Doc Buddy Journal before as well around labor shortage, and I want to key on that for just a little bit. Obviously, the ASC segment, as it were, was spared from the meaningful use rules in that High Tech Act in that ARRA 2009 law, and that has left a lot of ASCs running off paper. Universally or just about universally, there's a practice management software in place that handles your patients, your scheduling, and your billing, and that's it. And that's like the extent of the adoption of technology. But I'm seeing and hearing more and more that, hey, we know there's a better way, and we know that it's technology, and we are now beginning to look at that and seriously evaluate it. Why do you think it has taken this long, absent a meaningful use type law, for that realization to come into focus? I mean, obviously labor shortage is part of it, but why are we getting serious about it now?
I think a couple of things are happening here. One, you have platform initiatives coming in from private equity investors, right? You've traditionally, back to that 2015 timeframe, you had a small number of technology actors in the space, very few EHR or documentation systems available for surgery centers. You had the hangover that we're all aware of, docs having battled through, sometimes having to put in a second or third system in their clinic, this disruption of their workflows that they were really not expecting, and a lot of the unintended consequences from what should have been an otherwise really good idea to digitize the healthcare community. I'm still behind that. I think we all would agree interoperability was lacking. As you have money coming into the space, it's really hard to manage business and prove out your investment thesis if you're having to dig into a bunch of on-prem systems that reside across the country. So I think there's a top-down initiative, at least on the billing side, scheduling, billing, the practice management that you alluded to. Let's standardize that. Let's go ahead and make sure that we're not having to interject unnecessary human labor into the process of rolling up a quarter's worth of data. So I think that's helping move the ball forward. I think from other healthcare segments, we're certainly seeing, advancement in EHR workflow. We all know Epic, Cerner, the big products out there, and how they're starting to integrate point solutions within the actual clinical applications itself. So you have providers that are working in other areas of the healthcare markets, providers that are getting trained. So there's a different set of expectations today than there was eight or 10 years ago in the surgery center space. And we're growing into that, not fast enough. And now you put on top of that some of the AI potential out there, and you can really kind of chart a course towards something to be highly effective for surgery centers. But there's a lot of ground to cover to get there.
Yeah, and we definitely need to dig deep into AI, and we are going to. I want to talk about anesthesia. Excuse me if I could say it properly, just for a little bit as well. When you look at the broader sort of macro environment for physicians in general, accepting anesthesiologists here, we're going to run up on a huge shortage of them, and we're really only a handful of years away. A lot of that is due to the dissatisfaction with their career choice. They're getting burned out. They're retiring early. Spoke with a physician earlier this week who said, we need to do what we can to keep these guys and gals practicing in the near term so that we can sort of buffer this shortage. But in doing that, in enhancing career satisfaction for providers now, you're going to then make more of them interested, or more potential providers interested in going through medical school, residency, and their fellowship, and then you end up with more physicians on the back end of this. Anesthesia is under some of the same pressures, but the number one self-reported cause, or really the top 3 or 4 self-reported causes for burnout, are around technology. Certainly anesthesiologists have to use some of this technology as well, but to a different degree. It's a different type of practice, obviously. When we look at this huge shortage of anesthesiologists in the market, and we're opening up, as a country and as states, we're opening up the practice of anesthesia to your mid-level anesthesia provider, and that's still not going to be enough. What's the answer? What do you think should be done?
Yeah, it's a big question to tackle, Eric. And I think I'd add to that you have some, at least in the short run, some downstream impacts from No Surprises Act, some reimbursement and payment issues that go along with that. So I think you do have to make a focused effort to bring more people into the profession. We have to do a better job of continuing to recruit, train, and deploy people in the marketplace, especially with an aging population that's only going to add more demand into the marketplace. And that's what we're seeing today. We're seeing more demand, but we have reimbursement issues that are getting in the way, to the point where you have even some lawsuits going on with I think FTC and some big actors that are in the roll-up space. So there's a lot of confusion out there that's having downstream pressures for the independent operators today. And we got to work our way through that. But as we know, that stuff doesn't happen overnight. So methodical education, I think, probably a big picture item around getting better workflows to meet providers within the EHR, I think helps. We've got a long way to go there, because we're still building out the community. You talked about being paper-based today. That's easy. It's known. It's efficient. It helps the throughput of the surgery center. but we're not going to be able to harness all of that information for improvements down the line. So a myriad of factors to get through, and I'm not sure I have a great answer on where we need to go to get this solved in the short, medium, and long term. Just keeping it in focus, keeping it on the discussion, in the main form of discussion for everybody to know that this is really what's unlocked the surgery center world. Innovation in anesthesia is what's allowing more procedures to come online. It's allowed for people to improve faster, have better outcomes. So we really need to focus on this and make sure we're not letting this one slide.
Absolutely. And then to that point, one of the key initiatives that Bill Prentice, the CEO of ASCA, shared earlier this year was around awareness that the general population of the United States has no idea what an ASC is, what it is that they do, why it's a rare win-win-win in healthcare too for the patient, the provider, and the payer. And he came on to say anything we can do to improve our standing and improve our stature sort of in the public mind, we need to be doing. And this lack of technology, which we're seeing get better, which we're seeing ameliorate, but you need to have data on outcomes as
That's right.
opposed to just patient demos. So I think that'll help the cause overall. And as the ASC kind of opens up, hopefully you get more provider involvement and it's a more attractive place for.
It's more attractive. You're going to see an initiative from CMS to continue to shift procedures to outpatient. So it will organically take care of itself, in my opinion, from that capacity availability for procedures as physicians become more comfortable moving more complicated things in there. We know we've got the simple stuff that gets done on the regular, but as we open up cardiology, as we maybe see more urology, obviously ortho MSK continues to push into that as a I'm a recipient of that myself recently. So we will see this move more mainstream. And I think, ASCA does a nice job of advocating for its members. But it's a tough task, right? It's a hard ball to push uphill year over year over year. So kudos to the team for getting the team that helped the legislation push through, that got the new 11 codes passed, including shoulder arthroplasty. So those are wins. It's incremental, but it's coming. And I think we'll have to rethink how what gets done in hospitals over the long haul, and that kind of asset light footprint of surgery centers is a fantastic answer for that.
We could talk till the cows come home about spending in the U.S. on healthcare, its percent of GDP, the amount of fraud, waste, and abuse that goes into that spend. And, there are much smarter folks than I that could make good recommendations there. So unless you feel really strongly about any talking points there, let's examine something that may help us with the amount that we're spending on healthcare for a variety of reasons, and that's AI, or at least so-called artificial intelligence, if it's not just machine learning and predictive analytics. Did you want to dive into healthcare's top deck of the Titanic moment, or do you want to address it kind of at large before we do?
I'll follow your lead wherever you want to start, because I'm just hearing about this AI thing. I think it sounds promising.
Well, let's before we look at this tweet thread, which listeners will have heard on a prior episode, it's something that's been turning over in my head more and more. And the more I think about it, the more I find a lot of it indefensible. We'll get there. We'll get there for sure. But AI in general, the advent of Chat GPT has sort of revolutionized a lot of work streams, content creation for marketing, for salespeople and their outreach, and the integration of this, or the inclusion of Chat GPT or LLMs, large language models, in actually prominent EHRs is really interesting. For me, from where I sit right now, and I want your take on this, David, sometimes this appears to be a solution in search of a problem. And here's what I mean. You're a physician. We've already said, and we already know that we're burned out because of all the technology that I have to use that doesn't really do what I wish it would do, which is help me treat more patients and provide better outcomes to patients as opposed to being my own scribe from the provider point of view. So now I'm going to be forced to make a choice. I'm either going to create my own documentation, like I have been doing with any number of inputs in my EHR. Maybe I use voice recognition, like something that DocWitty provides, or maybe I do have a scribe. And it's going to say exactly what I want it to say. And when I click save, I'm done with it. The other end of this, the emerging end, the LLM end, the chat GPT side of things is now I'm going to click a button and I'm going to have the instant generation of
Mhm.
the documentation, the communication, whatever it is that I need. But now I need to go edit it because my name's on it and I'm signing it or I'm sending it to the patient. And it's sort of a 6 to 1, half a dozen to the other type argument. What's going to take me more, or better put, what's going to take me less time? The editing and the review, or just doing it myself?
Mhm. We're in early innings here, right? Generative AI, the ability to produce something new from a set of data. We're in the 1996, 97, 98 timeframe where we were just sort of opening up the internet. There's so much activity. It's overwhelming. It's literally everywhere. It's my feeds are filled with. I can't keep up with articles or podcasts or insights on where we're going with AI in healthcare. But it's clear that it's a radical game changer. It fits into the narrative of what we talked about with provider burnout. And so I think point number one is that for surgery centers or for general practitioners or any subspecialty, is AI is not a replacement, right? It is to be brought in to help physicians and nurses be better at what they do to practice at top of license. I think that's a term I'm hearing much more frequently now. I want to practice at top of license. Okay, great. What can we do to backfill that and take away the things that humans just innately are less effective at than a computer system, right? So there's so much ground to be made up here. We're still trying to figure out how is this going to be done on a mass adoption level, and we've got a lot of things happening in a time compressed manner, probably giving physicians across the board some pause of like, wait, this is going to happen too quickly. I want to know not just sort of the math behind the way this works, but I want it to be a credible thing for me. What clinically, how is this going to help clinically? And I think I listened to a talk by John Halamka at Mayo Clinic, and he kind of nailed that down with, we're going to provide data sets that we can prove to you, physician, that are going to be beneficial to you adding into your workflow. Now they're way out there in terms of sophistication and budgets and capabilities. That doesn't necessarily translate today into the surgery center world because we're 8 to 10 years behind where the hospital segment is. But that's the gap we need to bridge, right? We need to get information in that helps physicians, helps nurses do their job so that they're not having to quote unquote chart in their pajamas.
Yeah, you're so right. The pajama time charting is killing the profession. It's literally
Mm-hmm.
killing the career in front of our eyes.
Mm-hmm.
And to be clear, I'm all in favor of technology augmenting provider workflows. As a patient, I'd love to have the expert opinion of my provider plus 10 trillion data points that a software can chew up and spit out and say, yeah, we agree with your provider, or
Mm-hmm.
maybe this needs to be considered. Everybody
Mm-hmm.
should want that. It's absolutely common sense. And that's kind of an easy segue into this healthcare's top deck of the Titanic moment thesis, where the thesis is what happens in the next year will define the next century of American healthcare, and basically everyone is ignoring it. And let's set the table just a little bit here because everyone is ignoring it. I'm not so sure. I think Silicon Valley has been bitten many times by an entry into healthcare. Look at Google, look at Apple, and all of the data that their wearables produce, and physicians say, absolutely not. That's not a part of my patient record. Too much liability, too much exposure for me. Among many other sort of traditional tech monuments, the big ones is what I'm trying to get at.
Mm-hmm.
So the folks that are on the ground in health IT, I don't think are ignoring it at all. But not to review this line by line once more, but it outlines that due to a scarcity of providers, which I completely agree with, the insertion of an insurance payer into the care, the inelastic demand and high trust, and then regulatory capture of healthcare, you're seeing sort of parallel system to the traditional, I have insurance, I use it when I go to the doctor and I get what I need done, versus this other end of the spectrum, which is cash for pay, where, and this is where I think the thesis becomes indefensible, where something like an LLM will replace provider responsibility over your care and allow a healthcare organization to scale to infinity, all because of the power and leverage of an LLM. Now, there's more to it than that, but David, thoughts at a surface level here?
Yeah, I mean, I think I agree with your assessment that a little bit hyperbole, right? Maybe I don't disagree with sort of the backdrop of what's driving things. I mean, we have any number of issues that we have to work through in the healthcare system: cost, regulatory, you provider training and onboarding and retention. All those things are true. We know that, right? Are we going to leapfrog in 1 year to some kind of magic singularity? No, that's not feasible, right? I mean, we have a recent executive order from the president of the United States that has a myriad of impacts on how this thing rolls out. So just by the regulatory environment alone, we know things will slow down. That doesn't mean the innovation engine slows down. I think that's going faster than ever. Today, tomorrow, we're going to see things come out, and you and I'll read something or hear something and say, "Oh, wow, that's fascinating." Are those use cases applicable today? Maybe, maybe not. It depends on on how they're connected into the system, and we still have to get around the substrate of the EHR today, and the EHR today becomes tomorrow's data repository, right? And so all things will live on top of that, because we can't just get rid of that. That's a documentation system. It's there for regulatory purposes. It's a legal safety net. All the things that need to happen. Plus, we need to know what goes on during an episode of care, right? What is going on for the patient, right? So we can record that and draw that out. And then you talked about wearables. We have all kinds of image capture, so many other clinical trials, all these other data sets that sit outside of that. I don't see it being feasible for us to just magically get to a position where all of that stuff is brought into some kind of longitudinal record that allows us to make the strides that we need to. Will this next year have profound effects on the future of healthcare? Yeah, I think it will. I think that's a legit statement, because we're going to compress the learnings from the last 20 years down to move forward. We know what mistakes we've made. We know what we think we should have done. And we all work around the technology frameworks that exist today. It just seems to me like it's a 3 to 5 year rollout or more to get across the board what we need to get done.
Sure. And I think where there is some merit in this top deck of the Titanic moment, it's not explicit. It's not in this series of thoughts. But when you look at the amount it costs, whether it's coming straight out of your paycheck, whether it's something that you are paying for, the amount that health insurance costs without any actual benefit to you at the time you pay for it, and then you go and pay to receive care, whether that's a copay or you're working down your deductible or whatever, whatever that is. I think there probably is a subset of folks that are willing to explore a completely parallel system, whether they're paying for traditional coverage through their employer, it's something they get from CMS or whatever. I think there probably is a subset of people, significant subset, that's going to have to go to some cash-based model, $50 at a time, $100 at a time for something that amounts to near emergent care or some type of critical care. Think about a bad case of the flu. That's not something you can just kind of like sit on your couch and write out every time. So
Yeah.
there's probably something to this, but I don't think that it's that technology is going to drive us, or let me rephrase that. It's not going to be that LLMs drive us to this parallel system of care. It's going to be economic pressure on individuals.
Right. I agree with that. I mean, when we talk about large language models, they have to be trained and tuned. That costs money, it's time. We have to work through the ethics and the bias of those. There's a lot to process there. Is that is that going to be a state where we can effectively help providers deliver care? Yes. But to your point, getting to what's going to happen in the interim, maybe away from the surgery center world, advanced primary care, Amazon's announcing, low cost insurance to Prime members. There will be disruptive forces out there that, help access to care at a primary care level, but that doesn't translate into the more costly world of surgery centers, right? We still have that. You can't deliver low cost surgery today beyond what is already being done in the outpatient setting, which is, it's phenomenal what's done today versus what's done in the hospital.
Oh yeah, I mean that is the low cost care, right? The low cost
That's right.
care.
That's right.
Well, we've kind of meandered. We've meandered around a bunch. Pressures on the ASC space, LLMs, healthcare's so-called top deck of the Titanic moment, which I think you can make a case for the last 35 years. We've had a top deck of the
Right.
Titanic moment with spend. Just kind of waiting for the band to stop playing, I guess. But on a little bit more proactive note, a little bit more rosy of a note, as we're looking towards a new calendar year, and I'll say the cliche. It's hard to believe. It's the week before Thanksgiving that we're recording this already. But as we're looking towards 2024, two-pronged question here. What do your surgery center administrators need to be doing now to get ready for 24? And then is there anything different that an owner slash operator slash physician should be looking at for 2024?
Yeah, I think we've touched on a lot of things. So the first part of the question, end out the year. Right now, everybody's heads down and in hair on fire mode because patients are coming in to exhaust deductibles. So the end of the year is always hectic and patient focused. Always patient focused, but the volume really kind of takes, I think, puts extra pressure on the administrators and staff at the surgery centers to prepare for the next year. So there's a little bit of a post-holiday regroup to get ready for 2024. And I know they're all in board meetings and planning. So I think probably a lot of it is just let's get our procedures done. And then looking into the new year, what are some other things we haven't touched on? I mean, I think one that continues to pop up, I think, is cybersecurity. I think we're getting into a world with a lot more bad actors. So, top of mind for me would be, how do we prevent unwanted activity? How do we protect our patient information? Are we training? Are we getting the people the right, the right, just ongoing oversight so that they don't unintentionally do something? I think the majority of breaches are just innocent mistakes, but they can be incredibly costly. And we hear time and time again that a surgery center is shut down because they can't access their information. And I think my understanding is a lot of times they're having to pay to get out of it. Cybersecurity insurance is getting harder, right? Insurance companies are way ahead of this. They've got all the data in the world they need to make things more difficult on the operating entities. So be mindful of that. Think forward on how you're going to pull together. If you have to have more sophisticated governance and controls in place, that's something that I'd want to spend some time on at an executive level to make sure that we're not caught flat-footed and we have to go renew and it's either a massive hike or it's a no. So I would be spending time on that if I were at a whether you're an independent or a management company, and I imagine that the larger the organization, the more time they have available to that. So that would be one area. Thoughts on that? Do you guys see some same trends? And
Cybersecurity is massive and massively overlooked. Everybody knows they need to be managing it, but this is much more than having a firewall at your data center. It amounts to a large amount of humans investing their time and learning what they need to be doing and what they cannot do. Because to your point, it's generally a small mistake that costs a healthcare organization or any organization a lot of time and a lot of money. It isn't that there's a hyper sophisticated group of hackers that are probing for weaknesses in your network and, oh, I'm in, you got the guy typing, got sunglasses on in front of his monitor. It's sending a phishing email. Oh, your password was reset, or we need you to verify XYZ piece of information. You're pointed to a page that looks like what you'd expect it to be, and then you just hand over your credentials. It's not that the NSA or pick your spy agency is after your data and there are
Mhm.
incredibly gifted technicians working to hack you. They're just asking you to give them your credentials. And a
Mhm.
lot of times that's all that it is. Phishing email. Somebody's unaware that that
It's a
is
text. It's a phone
a
call.
text, right?
I
Yeah.
mean, Vegas was brought to its knees by a phone call. So get through Vegas, I can assure you that the independent centers out there are vulnerable because people are busy. People are wearing multiple hats, and it seems legit. I have to tell my parents, because they get 1,000 emails a week asking for some ridiculous thing. Look at the email address. Does that make sense to you? Is that a legit business, or is it some nonsensical, weird, garbled thing? And if it doesn't look right, don't click on it. Right? Don't
Yeah.
respond to that. Don't respond to that text. Just delete it. If somebody really needs you, they'll call you on the phone.
That's right.
But if they call you on the phone, be willing to take a step aside and go ask the right questions to supervisor, to an owner, whatever. Is this legit? So I hope we can find some common sense approaches to weed this out, because it's time and money, and you're losing procedures, and you're actually having to come out of pocket cash to get out of this predicament that nobody intended to be in. But I know how maddening it is for folks, and that does kind of, I think, unintentionally bleed over into technology adoption, because it's perceived as a technology based problem.
Hmm.
Um, maybe not, right? Sometimes it is, sometimes it isn't. So I would say, just be on guard all day, every day.
It's especially tricky because the technology aspect of it, you can solve that problem with the swipe of an Amex. Like if you don't already have the right hardware in place, or you don't have the right technical expertise, just buy it, pay for
Hmm.
it, and then you move
Hmm.
on. It's the in the business they call it social engineering for somebody trying to get you to give them their credentials. That's an HR problem. That's a
Hmm.
training problem. And
Hmm.
sure that may be under the compliance umbrella, but that's a human resource knowledge gap if people don't know that they need to be aware of that.
Hmm.
That
You
makes
said
it
something that's, I think that's an important thing. It's go ahead and pay for it, budget it, think about it, be mindful of what needs to come down the road. And I know surgery centers are strapped. I know there's some dynamics around the ownership models, but I think spend is important, not because I'm a technology vendor, or at least I used to be.
it's easy for us to
But
say. Go ahead and pay for
yeah,
it.
and I think and this sort of leads into one other thing that maybe I would like to see. It's not really a trend or things that I think have to be top of mind, but I really believe in the modern consumer retail experience, and I think healthcare lacks that across the board, right? There's some pockets of excellence. Not that the people aren't great. It's not a people thing. It's a process. How do you onboard a new patient? How do you bring them into your clinic? How do you communicate with them? And that's a spend thing a lot. And the intentionality of the staff is there, right? More often than not, you walk away from these nurse interactions, you're like, I love that person. She's awesome. He's great. I'm entrusted. I trust in the care that they're going to provide for me, but I have to go do something in triplicate now, and it's time to go ahead and move into a world that opens up. Right? We talked earlier about how do you get patients coming to a surgery center, make it easy for them, make it dead simple, make it so attractive that people already don't want to go to a hospital coming through COVID. That's where sick people go. Like let's go to the areas that are there for preventive care, and obviously we're fixing problems in the surgery center world. We know what we're fixing, but just make it easy for them. Make the paperwork seamless. Make it so attractive to me that I want to be there. Have the environment that for those of us who may be apprehensive about our procedure, it's more than just empathy from the staff, and again they're fantastic at doing that and allaying fears, but it's the environment as well. So I'd love to see a move, as maybe impractical as it is, to make these facilities more welcoming where they can.
I think that's a really interesting point, and not to drag us way out off on the tangent of talking about prep for 2024, but there's almost there's almost a push and a pull there that healthcare seems to know that this is a good thing. We want to do it. How do we do it? I don't know. I think it comes down to paying, as you said. You have to have technology in place, or at least a baseline of technology to even have a true consumer experience at your facility or at your organization. So we're going towards that as an industry, but then the push towards it is with the Gen Z population kind of coming into its own and needing to be responsible for its own care as it goes to college and grows up. There's a level of convenience now with anything that's not just expected, but if it isn't met, then they're just not going to do it. And we're speaking broad generalities here,
For
but
sure.
the tolerance of a bad process is going to fall off a cliff as baby boomers sort of,
Yeah.
finish their run, great run, obviously, but as they kind of fade away and their healthcare is dictated or managed by others in their
Yeah.
family, there's not going to be, oh, I had to call 3 times for an appointment. It's going to be, I couldn't get an appointment on their website, so I'm not going there.
Right. And I know the spend is there. So if I can't have a clean experience and I have this big chunk of my disposable income going towards this thing, that seems like a detractor in the generationally. I see it in my kids and their apprehension to do things is just not turnkey. And I think that will, as their spending increases on things that are less entertainment based, for at least for my older children, there is going to be a demand on that. So maybe that's what drives it, and you'll have innovators that come through and create different models of care delivery, not episodes of care, but value based care. Right? How are we going to go about this bundle of of care versus just transactional? So and that maybe be something else we'd be thinking about at surgery center levels is how do we participate in those? What's a responsible participation in value-based care? How can we do that effectively without losing our shirts, right? Because there are factors outside of our control that we have to live through to figure out how this works best.
And oh my gosh, I know we're coming up on time, but that even brings another thought to the forefront is managing the profitability of cases. The administrators I've spoken with over the last 6 months are being this isn't the right way to phrase it exactly, but being held to a higher standard by their physicians and by their owners, where it's like, what do you mean? This implant cost me this much. This guy only paid that much for his, and you might even be in the same facility. So
Mm-hmm.
that is for sure a thought for 24, making sure that
Mm-hmm.
all your cases remain in the black.
That's right. Yep. Being good about, upfront, how do we evaluate, on a pro forma basis? What do we do? I think there's some tools hitting the market that can be really helpful with that. I think the sophisticated administrators do stay on top of this, and you have implants, you have contracts, you have different variables in there that trip people up. But yes, that's something that I think to bring back AI into this over time gets really effective because you're getting out of just the pure documentation. Let's just say whether it's paper or EHR, the basic structured data that gets captured, right? That's what an EHR does. It captures times, it captures medications, it captures allergies, it captures what happens on game day. But we need to fold in rich data, whether that's GI images or whatever it is, wearables, all this superset of information that gives a more comprehensive view of why provider X and provider Y have differing outcomes. Right? That there's some really, really, really exciting stuff on the forefront. So being mindful of that in 2024 is education. Stay on top of this. Don't let this trend get away from you. You hear pundits and people that put tweet storms out. Don't get left behind, and there's some truth in that. It's time to be educated on technology because it is a force multiplier for you in a surgery center. If we think the labor shortage is going to persist in some part for a period of time, whether we like that or not, we have to find a way to bring technology back behind the providers to make them more effective. We've got to take some of the administrative burdens or all of the administrative burdens off their plate so they can pay attention to the patients. That's what I want. I'm a patient. You're a patient. We don't want somebody sitting there staring at a computer screen, typing in and having to ask us a series of questions. Click, 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 click. And the providers don't want that either. It takes away from the experience. And we should do better.
Yeah, it's time. It's time to grow up as an industry. And I'm speaking to the healthcare organizations out there. You can't hire FTEs. You can't throw people at problems anymore.
Mm-hmm.
Use technology to be doing what you should have been doing 10 years ago.
Mm-hmm.
It
Mm-hmm.
exists now.
Mm-hmm. And as technology vendors, we've got to find a way to do that in a cost-effective manner, right? Because you can't soak these entities with subscription after subscription after subscription after subscription. It's overwhelming. So I'm empathetic to the buyer who has to weed through all of these things to say, is this really better for me? I mean, I love what this does, but in how does this fit into a holistic picture for me? And I realize that. So we have to be better at connectivity, right? If meaningful use had been more mindful of interoperability, I think we'd be in a different place. Woulda, shoulda, coulda. Okay, so now here we are, and as vendors, it's hard to allocate resources to that connectivity because we all have our own agendas to move forward. So it's tricky, and but it needs to be solved. I know there are intermediaries that help, and companies out there that are thriving by creating this connectivity, and that's great. Like, let's just continue to make it easy, continue to be open, move to an API infrastructure, and get clean data exchange that's de-identified in a way that we can use it for betterment of care.
What else can you say to that? Thanks for picking me up on my very vendor centric point and for providing the balance there. That was really well put because it's true. There's a vendor, 10 vendors out there for every one problem, some good, some not so good, some in the middle. And you do have to make the right choice with limited resources. So, very much understand that. David, where can folks connect with you? Are you active on any social medias or anything else you'd want our listeners to know about what you're doing?
Thanks, Eric. I appreciate it. I'm not terribly active, but I do. LinkedIn would be the best place to start. And if you have show notes or something, I can flip over my profile. But that's about where I live. I don't really get too much outside of that for fear of crossing paths with my kids and having them terrified of dad kind of stooping on them. So I'll send you my profile link, and yeah, I'd love to continue conversations. Obviously, it's a pleasure to talk to you always, and appreciate having the opportunity to sit down with you. And thanks to the Doc Buddy team for making this available to public. More information, more awareness, more general discussion, I think is better. And so creating a short form piece that the surgery center world can benefit from, or other healthcare segments as needed, I think is a great thing. So kudos to continue to do this, and thanks for letting me hang out with you for a short period of time.
Oh, loved it. Loved chewing the fat with you. Thanks for sharing your expertise. And we said this before we started to record. It'd be really easy to do this and just record a commercial every week. Not only is that bad content, though, we're very serious about flying the flag for physician workflows, reducing burnout. We fly the ASC flag as high as anybody out there, except with the exception maybe of ASCA, since we're not going to the Capitol and doing any lobbying ourselves. But we're totally invested and totally bought into making healthcare better in our own little way.
Good stuff. Thanks for doing that.
Our pleasure. And on behalf of the entire Doc Buddy team, thanks for listening. We will catch you on the next episode of the Doc Buddy Journal.